Onc Live Insights is a video editorial program produced by Onc Live.
So most of the patients we treat are good and intermediate risk group, which means they are good performance status. And we'll speak later on with poor risk patients, but good and intermediate risk patients are the majority of the patients. Usually we use TKI because it's an oral drug which is more convenient to use. We still use interferon plus bevacizumab in a small cohort of patients, mainly those with indolent disease and lung metastatic disease, because they are probably the most likely to respond to this drug. But in most of our patients, we are going to use VEGF targeted agent as TKI, which are sunitinib or pazopanib, actually. So that's, I would say, 90% of our patients will receive these drugs.
I do think that it's open to the physician to choose between sunitinib or pazopanib or interferon bevacizumab, or even the cytokines only. I do think that you have to take into account patient comorbidity. If the patient is frail, I would say certainly choose pazopanib. It will be easier for the patient. The quality of life will be better. In a patient who is really fit, doesn't have comorbidities, I do think it probably doesn't make so much of a difference if you choose sunitinib or pazopanib, although the toxicities of sunitinib may be more pronounced looking at the data in COMPARS. Initially, years ago, when a patient was really high risk in the sense that the tumor burden was large and liver metastasis, for instance, we tend to believe that the stronger drug we can give and the faster the response will start to be there. That's the important drug to choose for. So I tended to prefer sunitinib over pazopanib in patients with liver mets and large tumor burden. I do think that based on the COMPARS data, that no longer holds, and that they're really sort of equally effective, and it doesn't really matter whether it's a bit more high volume, yes or no. So personally, I like pazopanib very much. I tended to use it in the very frail old patients whom nobody wanted to treat, and you get used to the pazopanib and the easy way of administration and the few side effects. Although also pazopanib can have severe side effects, so it's not for every patient, and you can still change TKI, of course.
Regarding the choice between sunitinib and pazopanib, we now have two studies which help us to make our choice. So the first one, the COMPARS study, in general said that the two drugs are similar in terms of efficacy, and there are some differences in toxicity profile, a little bit in favor of pazopanib. So that's why PICES study was important, because this was a patient preference study where the two drugs were compared in the same patient population. Patients received both drugs and could say, I prefer one drug versus another one. And 70% of the patients did prefer pazopanib when they received both drugs. So actually, when I speak to my patients, I explain, we have two similar drugs in terms of efficacy, and we have one drug which is preferred by most of the patients. Of course, there might be differences, there might be some different schedule of sunitinib, but still actually we know that pazopanib is preferred by patients, and I honestly use more pazo than I use sunitinib actually in my patients. In addition to PICES and COMPARS, we're unable to find predictive factors that one drug would be better than another one. So actually, I don't think I select sunitinib or pazopanib based on comorbidities, on toxicity profile, and so on. So it's mainly a question of choice on attitude I have, because of the data we have. So I don't think the patient characteristics are going to influence my choice anymore. So I choose pazopanib in most of my patients, probably except the non-clear cell histology group where we don't have enough data with pazopanib.